Hello everyone, my name is Mahmoud Ismail. I'm one of the second year internal medicine residents at Creighton University in Omaha, Nebraska. Today I'm going to be talking about an interesting case of left main coronary artery spasm that was actually misdiagnosed as a case of severe coronary artery disease. So as we all know, coronary artery spasm is pretty common and it can be difficult to diagnose given that it can present in various ways, from silent ischemia to chest pain to even sudden cardiac death. In this case, I'll be describing a patient who had isolated left main coronary artery stenosis during her left heart cath, which was misdiagnosed with severe left main disease requiring surgical referral for a possible CABG. Thankfully enough, this patient underwent a CT coronary angiogram prior to her surgery, which unmasked spasm as the underlying cause of stenosis and prevented any unnecessary surgery. So here's our case. It's a 55-year-old lady with a history of hypothyroidism who presented to the ED with exertional retrosternal chest pain that radiated to her neck and left arm. She also had associated shortness of breath on exertion, nausea, but no vomiting. She denied any cough, orthopnea, paroxysmal nocturnal dyspnea, or diaphoresis. In the ED, her vitals were pretty stable and her physical exam was unremarkable. Her chest X-ray was normal and her EKG showed T-wave inversions in the inferior leads as seen in figure 1, which was seen on her prior EKG obtained two years ago. Her cardiac troponins were within normal limits, and her lab tests, including CBC, CMP, lipid profile, and hemoglobin A1C, were all unremarkable. We obtained an echocardiogram which revealed a left ventricular ejection fraction of 60 to 65% without any regional wall motion abnormalities. We then risk stratified the patient using different scoring systems, including the heart scoring system, the TIMI scoring system, and the GRACE scoring system, and she was classified as intermediate risk, and she was deemed appropriate for an ischemic evaluation. The patient was referred for an ischemic evaluation with a nuclear stress test in the outpatient setting, and we were able to obtain the rest images. However, upon administration of the regadenoson, she had a severe reaction with blurry vision, headache, dizziness, and shortness of breath, which terminated her nuclear stress test. She was given theophylline with immediate reversal of her symptoms, and she was sent to the ED for further evaluation. In the ED, her cardiac troponins were within normal limits, and her EKG showed similar T-wave inversions in the inferior leads as seen during her prior hospitalization. Cardiology decided to take the patient for a left heart cath, given that she failed her outpatient ischemic evaluation, and her left heart cath showed an isolated 80% stenosis of the distal portion of the left main coronary artery, as seen in figure 2a. Given this 80% occlusion of the distal portion of the left main coronary artery, the patient was referred to CT surgery for a possible CABG. However, given that this patient did not have any risk factor of coronary artery disease, and given that she had an isolated stenosis with clean other coronaries, CT surgery decided to obtain a CT coronary angiogram prior to proceeding with CABG. Her CT coronary angiogram showed normal left main coronary artery without any stenosis, which suggested the diagnosis of a spasm rather than coronary artery disease. We then took the patient for a left heart cath again, which showed a normal left main coronary artery as seen in figure 2b, which also supported the diagnosis of coronary artery spasm rather than coronary artery disease. This patient was discharged on calcium channel blockers, which was amlodipine, and I followed up with her in clinic 3 months later, and she denied any further episodes of chest pain. So here are my take-home messages from this entire case. So it's really important to know that coronary artery spasm can angiographically mimic coronary artery disease, which can potentially lead to a misdiagnosis. And in cases of left main coronary artery stenosis, such as our case, it can lead to inappropriate referral to CT surgery for CABG. CT coronary angio is a really good non-invasive imaging tool that can help unmask left main coronary artery spasm and therefore help prevent any unnecessary surgery in such cases, such as our case. And finally, it's really important for physicians to keep a high suspicion for coronary spasm, especially in patients who present with chest pain and they don't have any risk factors for coronary artery disease, such as hypertension, hyperlipidemia, diabetes, smoking, and obesity, and especially in those who have no coronary atherosclerosis in the unspasmed arteries. In other words, in those who have isolated stenosis with clean other coronaries, it's really important to keep in mind that this is most likely spasm rather than coronary artery disease. Thank you everyone for listening, and thank you for your time, and please let me know if you have any questions.